Okay, the next talk is on sexually transmitted infections in the adolescent. Now, I want to actually make sure that you understand that not all teenagers are having sex all the time and getting into trouble. Most teenagers are not doing this, but we want to make sure that you have the tools to talk about this in your practice. Because the last thing you want, obviously, and Dr. Juana was wonderful in talking about preventing pregnancy. Thank you so much for mentioning that. But I'm going to be talking about preventing sexually transmitted infections in the teenagers, because it is something that is very common and that is something that we as pediatricians do not talk about enough and screen for enough in our practice. So I'm hoping to give you some information and tools to do this when you go home. So in this talk, what I want to do is describe the scope and risk factors for sexually transmitted infections in adolescents, discuss particular sexually transmitted infections that occur, and talk about how to assess, treat, and even prevent STIs in our teenage patients. From the CDC report in 2015, the incidence of infections and STIs in young adults is 20 million new cases per year. 50% of these occur between the ages of 15 and 24. 50%. This is a lot. And this is basically something that can be prevented, where there is a total of 111 million infections per year, and most of the new infections occur in young males and females. Direct medical costs of STIs in young people, $16 billion per year. What I wanted to talk about briefly is that before I came, I went online and talked to the CDC about the infection rates for STIs in Mexico, because I really wanted to figure out how I could help you with your patient population. And so for those of you that have information about the screening and the detection of STIs in our Mexican young people, please come up and ask me questions, and let's talk and share our stories. Because it was very difficult for me to find a specific number of STIs in our Mexican teenagers, or even in those in Central America. I know it exists, but it was very hard for me to track the information. But let's go into why teenagers face an increased risk for STIs. And Dr. Juana was very smart in bringing up the different things that we talk about with teenagers, including the biologic, cognitive, behavioral, and social things that affect our young teenagers. So the biologic risk factors are real, and I know that this is something that you've taught before and remember from your practice or in your training. But the adolescent cervix is much more susceptible to the STIs. Lots of our teenagers have lack of immunity, so their immunity to STIs is less robust. Their introitus is smaller, so there can be more microtrauma, and if so, there's more places for viruses or other STIs to penetrate. So dry traumatic sex can lead to traumatic introiti, and basically it leads to an increased susceptibility to infections, basically because the barrier is broken down. And cognitively, the teenagers are at much higher risk because it's very difficult for them to plan ahead for the possibility that they can get an STI. As was mentioned by the previous speaker, many of our teenagers go to parties. They may drink alcohol or smoke marijuana and then become very much cognitively disabled, and they are unable or can't remember what happened and unable to say no. And there's something called serial monogamy, which means they have one partner for a week or two, and then they have another one, and then they have another one, and then they have another one. Multiple partners can occur in a very short period of time. And then there's something called a personal fable, which might be difficult to translate, but I think you can understand this, which is basically that this can't happen to me. My boyfriend has never had sex with anyone else, and I know that he is totally faithful to me. So, with that in mind, other people get STIs and I don't. We all know this, right? Yet we love these kids. They're our future. This is the future of our country as our teenagers. So the behavioral risk factors, and I love the fact that our talks just basically coincided and slipped right into each other in terms of these different colors. So the age at first intercourse is important, talking about the new partners, multiple partners, substance use, and very important, as I mentioned in my last talk, to talk about partner violence. So the behavioral risk factors are extreme, especially with older partners. Many times there's a power imbalance when the partner is significantly older than the teenager. Makes negotiation very difficult. And it increases the risk of involuntary intercourse. And also it increases the risk of the male partner refusing to wear a condom. And then ultimately an increased exposure to STIs. So empowering our young women to say no is an extremely important part of our job as pediatricians, as parents, and as members of society. And also extremely important to discuss men who have sex with men, or MSM. 75% of all primary and secondary syphilis cases were attributed in 2013 to MSM. 4 in 10 MSM are also infected with HIV. It's a real issue, something that needs to be discussed with our patients, especially those who are experimenting with both males and females that are still experimenting with different sexual partners, determining who indeed their sexual identity ultimately will be. Then there's the social and institutional risk, which is an extremely important part of preventing STIs. Basically, teens aren't screened or treated because they're not coming to see us. We're not getting to where they are, like in the schools, in the malls, in the public health clinics. There's significant concern about confidentiality. There's a stigma that if you go to a STI clinic, then you're one of those girls. And that can be initially a problem. And then really important is lack of education about risk. I was talking at a group of 10th grade girls, which were 14, 15-year-old girls, and the first question they asked me was, what does it mean? What does consent mean? What is saying no? How do you say no? And these were 14 and 15-year-old girls who I would have thought already knew how to say no. They certainly say no when they want to have a conversation with their mom about cleaning their room or doing the dishes. They're very good at saying no to that, right? So I find it fascinating that in one room, they're very easily, they can say no very easily, and in other rooms, they can't. So again, what is the efficacy in condoms? This was just discussed, but very important to know the data, to talk about the data with our kids. They're looking this stuff on the internet up faster than we are. They come in with their phones and they're looking up stuff. I have to tell them to put their phone down, actually, because they're looking, maybe they're not even talking to me. But I want to point out to them that there's a lot of information that helps them understand why condoms are important. Prevents HIV 85%, 70% HPV prevention, consistently can reduce the risk of gonorrhea, chlamydia, trichomonas, and prevents HSV and syphilis. This is very important information to tell our patients, especially when they're taking hormonal contraception, especially when they're on the birth control pill, or the Mirena, or the implant, or the injection, or the ring, or the patch. They're not protected against STIs. And this is just some backup for you in case you're not sure whether you should do this. These are all the agencies, the AAP, ACOG, AAFP, CDC, USPSTF, all of which recommend patient prevention counseling that occurs and anticipatory guidance every year. Busy slide, I know, but basically what this is, I'm trying to show you, it is a slide about making sure that there's a reproductive health visit that's very teen-friendly, which means that the parent isn't sitting in the room the whole time you are trying to take a reproductive health history. So it's hard, especially when you're busy and you have 10 minutes to cover everything from car seat belts, helmets, And you also have to talk about safe sex. But it's also really effective to make sure that at some point in your interview with a teenager, beginning probably around age 12, is that the teen is seen with you alone. And obviously a 12-year-old isn't necessarily sexually active, but if you can prepare the parent that you're going to do this every year, you're going to talk to a teenager alone, making sure that you will tell him or her if there's anything unsafe that is happening, the parents will feel more comfortable leaving the room, and the teenager will feel more comfortable talking to you. So let's jump to a case, Erica. She's a 16-year-old, presents with dysuria and vaginal discharge. What's your initial differential diagnosis, and what other information do you need? You need to take a sexual history, and we try to make it very easy by using 5 Ps, which is how many partners have you had? What have you been doing to prevent pregnancy? What have you been doing to protect from STIs? What kind of sex have you had? And whether you've had a history of STIs. 5 Ps. And it is really interesting because you can get a lot of information from this part right here, how many partners they've had. And a lot of people will tell you everything about their sexual practice. And that's not that you need to know specific details of everything they've done, but you just want to know what to screen, right? You want to know whether you need to do an oral swab for chlamydia or gonorrhea. You need to know whether you need to do an anal swab for HSV if there's sores. You just need to know a history of this. So let's go back to Erica and go back to the 5 Ps. She's had several episodes of unprotected sex in the last few weeks with her one male partner, her only lifetime partner. She's not on hormonal contraception, but uses condoms most of the time. And I always love to hear most of the time. Specifically, does that mean every second or third time? Or you wanted to, but didn't? What does most mean? She engages in oral and vaginal sex. She's had no history of prior STIs. And then you go back to her diagnosis of dysuria when she was complaining of painful urination. Could this be a urinary tract infection? Could this be a cervicitis? Could this be herpes? Or could this be trauma? A big concern and a question, and it leads to a lot of roadblocks and barriers to taking a sexual history, is because you're concerned, oh my goodness, I have to do a pelvic exam. I don't want to, I don't have time, I haven't done it in a long time. And the answer to that is not necessarily, and I think this is really important. She's sexually active, she's symptomatic, so basically her pelvic exam is something that you need to do because she's symptomatic. But let's just say Erica didn't have any symptoms, but she was concerned because she thought maybe she'd been exposed to an STI. The cervical cytology guidelines are really important for you to remember after today. There's no need to do a pelvic exam in this young woman if she's asymptomatic. In fact, you don't need to do a pelvic exam until a young woman is 21 years of age, regardless of when she started to have sex. And this is very important. I think that when I was in training, we had to do a pelvic exam the second a girl started having sex. Which was just a huge barrier for bringing the girls in, and a lot of us didn't want to do that, so we just stopped seeing teenagers when they started having sex, which is not a good thing, because pediatricians are very good at talking to teenagers. I know that in my home, I have three kids. They're older now, but one's still a teenager, and he knows I have no problem talking about sex with any of his friends, which is hugely embarrassing for him. I don't care. I'll talk about it to anybody. But it is very embarrassing for my son. But by the same token, most of my kids' friends will talk to me quietly in the other room about questions because I talk about it. But basically, the key point is that they don't need to have a pap smear and a pelvic exam until they turn 21, unless there's symptoms. And then they have to have it every 3 years. And if you have questions about this, I'm available at the end. So basically, Erica is sexually active and she's at risk for cervicitis because she's got a vaginal discharge. And the most common vaginal discharge etiologies from the cervicitis are chlamydia and gonorrhea. So chlamydia, up to 80 to 90% are asymptomatic, but they can present with prolonged menses, spotting, dysmenorrhea, so that was the initial talk I gave when painful periods, painful intercourse, dyspareunia, or vaginal discharge. In males, up to 90% are asymptomatic, which I think is an extremely important fact to tell our teenage patients. 90% have no idea that they have chlamydia. And the sequela of untreated chlamydia, PID can occur in 10 to 15% of untreated chlamydia, which can again lead to PID, which may lead to poor fertility 10, 15 years later, which we do not want for our young women, and can lead to increased HIV transmission. Again, routine annual screening for women is for all sexually active teenagers less than 25. This is basically supported by the major organizations in the United States, including CDC. So routine annual screening, what is that? Let me go back one. So in males, routine screening is not recommended unless they are teenagers that are frequently having sex, they're MSM, males having sex with males, they are in correctional facilities, and they've had multiple partners. So if you think about this in the adolescent, annual screening is probably recommended, but basically you have to tease apart a little bit the frequency of their sexual activity. In gonorrhea, routine gonorrhea screening is also recommended in all sexually active teenage girls. This is again supported through the major organizations of practitioners and the CDC. Gonorrhea symptoms, about 50% of girls are asymptomatic. And if they do have symptoms, they have vaginal discharge, bleeding with intercourse, and males, again, 50% asymptomatic. But if they are, they have pus draining from their penis, burning urination, and painful swollen testicles. Routine screening of gonorrhea in males are adults, males having sex with women, basically individually and population-based screening. MSM, it's recommended. And again, the other agencies are not as firm on routine GC screening as they are for chlamydia screening. The sequela of untreated gonorrhea include female cramps, PID, infertility, ectopic pregnancy, HIV, all very unhappy and sad outcomes for untreated gonorrhea. For males left untreated, rare, but it can be prostate issues, epididymitis, and HIV. What do we do and how do we screen? The recommended screening is the nucleic acid amplified test. For women, a self-collected vaginal swab is preferred. However, urinary samples are acceptable. For males, urine is the preferred method for screening. And again, another myth to bust is that many still think that in order for them to be screened for an STI, they need to have a urethral swab. Absolutely not. We do not do that anymore. They just need to pee into a cup. And it's important for them to know that. Again, as you may remember, it's a not clean catch, but it's a dirty void, first void. That is what we use preferably. Many think that the preferred and the gold standard is culture for chlamydia and gonorrhea, but this is not necessarily the gold standard at this time, especially for rectal and oral swabs. For rectal and oral, it is definitely the nucleic acid amplified test, which is the best screening for gonorrhea and chlamydia. And definitely important to remember, back to what I said before about the asymptomatic screen, you do not need to do a pelvic exam. A girl can come in, want contraception, have had unprotected sex. You do a pregnancy test. You do a urine NAT for chlamydia and gonorrhea. Boom, out she goes. You can give her contraception, and you've had a wonderful visit and helped her. She comes back positive, and we'll talk about the screen and the treatment now. So let's just say the gonococcal infection came back positive. The gonococcal NAT came back positive. The treatment is ceftriaxone IM plus azithromycin. We don't recommend quinolones in the United States for gonorrhea at all because we have significant amount of resistance to the quinolones in the United States due to overuse. Again, if you don't have ceftriaxone available, you can use cefixime orally. The chlamydia treatment is azithromycin 1 gram in an oral dose or 100 milligrams twice a day of doxycycline. This is extremely important, which is the partner notification. And expedited partner notification is very important to prevent the spread of the STIs. This is, and again, I was not unaware and couldn't find an equivalent EPT when I was screening the Mexico guidelines in terms of treatment and partner treatment. But in the United States and in other areas which have access to EPT, the recommendation is that the partner get treated. Through the EPT program, especially through an STI or STD clinic, the partner gets treated without notification of why they're being treated, and it varies state to state. Briefly talking about HIV screening, we offer routine screening to all adolescents by the age of 16 to 18 when HIV prevalence is greater than 0.1%. The ACOG AAFP also recommends screening, as you can see. The CDC recommends screening all youth aged 13 to 64 in all health settings. And the Preventative Task Force recommends HIV screening for anyone between the ages of 15 to 65. I was just going through the UN AIDS, WHO, and other guidelines to help you learn a little bit more about condoms and HIV prevention. So I've just pulled up some websites about this for you. Also available to you if you're members of the American Academy of Pediatrics. The Red Book has STI chapters in English and in Spanish. A brief mention on HPV vaccination, which is an extremely important topic to talk about. And I know that a whole topic can be on talking about vaccinations in adolescents. But the uptake of the HPV-4 vaccination has been occasionally problematic in the United States, probably because of poor education, both of our teenagers, our parents, but also of our pediatricians and family practitioners. They're not recommending it enough. So this is another plug to start really talking about HPV vaccination. And the routine vaccination we recommend starts at 11, but you can actually go up as late as 26. And it's a 3-series vaccination, one at 1 month, and then the final one at 6 months. Also, we recommend hepatitis B vaccination as well. And finally, hepatitis A vaccination is also recommended for those at risk. There's multiple places where you can learn more about STIs, and I know there's a lot of information I was trying to present this morning. You've been very, very kind to let me talk very fast. But these are the CDC guideline websites, and the new guidelines, the 2015 guidelines, are very current and very helpful in terms of having placards, cards, and information in both English and in Spanish. There was a webinar that the CDC put on actually 2 days ago, which is up and available for you to review, looking at STI screening for those of you and how to do it. So again, if you go to the CDC website, this is free, and this is an excellent webinar. Actually, I was able to see it already on sexually transmitted information and information for you. Again, I would love to stay and talk to any of you that are interested a little bit more about HPV vaccination and what's going on with that in Mexico. And I would love to talk to you more about how to work on screening and prevention and how to help you help your teenagers if you have time. Muchas gracias por otra vez. Thank you very much.